Uh, I welcome you all to this Bihar Orthopaedic Association CME on shoulder arthroscopy, which is being organized, done by the Patna Medical
Recording in
College Hospital.
progress.
We have tried to make it very concentrated on shoulder, especially related to cuff and the bankarts part of thing, dislocation. Uh, we have got very eminent faculties who are really expert of international caliber, like Dr. IPS Oberoi, Dr. Deepak Joshi, and Dr. Sandeep Singh, who have two of them are from Delhi and one from Bhubaneswar. Other than that, we are really very good local faculties. We have tried to keep it very concise and concentrated. So without much ado, with the permission of President Sir, I would like to start the program by requesting the chairpersons of the first session, Dr. Ranjit Kumar Singh. Sir, please to the dais, sir. Dr. Om Prakash and Dr. Sameer Rahman to the dais, please, sir. Requesting all speakers to stick to their time. If times allow, the chairman are requested to allow a couple of questions. If the time doesn't permit, you can skip the question answer session. Thank you very much. Handing over to our chairman.
Good morning. Now, in this CME on arthroscopy, we are starting the first session, and our first speaker is Dr. Parveen Kumar Sahu. He will be telling us about clinical anatomy of shoulder. So, may I request Dr. Sahu to please come and deliver your paper.
Very good morning to all of you and respected chairperson, sir. My topic for today is to start with anatomy of the shoulder joint. किससे बढ़े? Shoulder girdle is composed of a scapula, clavicle and humerus proximal end, and articulation is between the rounded head of the shoulder and the shallow pear-shaped glenoid cavity of the scapula, and this form the shoulder girdle complete. And we will today speak about the anatomy of the shoulder joint, which is mostly the glenohumeral joint and supported above with acromion, coracoid and coracoacromial arch. The articular surface are covered by hyaline cartilage, and the articular glenoid cavity is defined by the presence of fibrocartilaginous rim called the glenoid labrum. This joint is synovial, and acromion of the scapula is in the top and coracoid is anteriorly. And it is a type of ball and socket joint, synovial joint, and the fibrous capsule is protecting this joint. The fibrous capsule surrounds the joint and is attached medially to the margin of the glenoid cavity outside the labrum and laterally to the anatomical neck of the humerus. Inferiorly, the capsule is thin and lax and allowing a wide range of movement, and inferiorly the fibrous capsule is attached a bit below, and this portion is called axillary recess. And many ligaments are surrounding and holding the structures, and this gives the stability to this shallow joint and also allows the mobility in a very wide range. Acromioclavicular joint between the acromion and clavicle, coracoclavicular joint between coracoid and clavicle, and this is in two part, trapezoid part and conoid part. Again, the coracoacromial ligament is very strong ligament holding and supporting it, the joint from the above. Coracohumeral ligament is attached with the proximal end of the humerus greater tubercle region, and transverse humeral ligament is there in between the two lips, two tubercle. It is connecting the intertuberculous sulcus. Glenohumeral ligament is protecting, attaching the glenoid to the humerus from inferiorly, antero-inferiorly mostly. And the tendon of the long head of the biceps is intrasynovial, and it is protected with the transverse humerus ligament. The glenohumeral ligament are three weak band of fibrous tissue that strengthens the front of the capsule. The transverse humeral ligament strengthens the capsule and bridges the gap between the two humeral tuberosity. The coracohumeral ligament strengthens the capsule from the above and stretches the root of the cricoid process to the greater tuberosity of the humerus. Accessory ligaments are coracoacromial ligament. And again, now coming to the synovial lining, synovial membrane. This is again the inside the capsule, and it is secreting the synovial fluid. Synovial membrane is hanging in the recess, axillary recess inferiorly, and the long head of biceps tendon is intrasynovial. It is attached to the margins. Fibrous capsule is attached to the margin of the cartilage covering the articular cartilage. It forms a tubular sheath along the tendon of the long head of the biceps brachii. It extends through the anterior wall of the capsule to form the subscapularis bursa also. Now, nerve supply from viewing from the posterior, the main nerve supply is axillary nerve, which is emitting from the quadrangular space below the teres minor muscle along with the posterior circumflex humeral artery. And other nerves are suprascapular artery along with suprascapular nerve emitting through the suprascapular notch and supported with the transverse superior scapular ligament. Articular branches of the axillary nerve and suprascapular nerve supplies all around the shoulder joint. Movement. There is wide range of mobility, flexion, since acromion is directed about 10 degree forward laterally and 10 degree forward also. So the flexion is slightly towards the medial side, and extension and flexion is on the anteromedial plane slightly. We have abduction, adduction, lateral rotation, medial rotation. And circumduction movement. When arm is extended, we can completely 360 degree rotate the joint. Distal part of the humerus is rotated fully. This is circumduction movement. Normal flexion is about 90 degree. It is performed by the anterior fibers of the deltoid, pectoralis major, biceps brachii and coracobrachialis muscle. Extension is normally 45 degree and it is performed by the posterior fiber of the deltoid, latissimus dorsi and assisted by teres major muscle. Abduction of the upper limb occurs both at the shoulder joint and between the scapula and the thoracic wall. It is initiated by the supraspinatus muscle. First 15 degree of the abduction is initiated done by the supraspinatus muscle. Later on it is mainly taken by the deltoid. And from 10 minutes नहीं हुआ है टाइम, थोड़ा शॉर्ट करते हैं. So supraspinatus muscle initiates the movement and holds the head of the humerus in the glenoid fossa. Adduction is up to 45 degree across the front of the chest, and this is performed by the pectoralis major muscle, latissimus dorsi, teres major, and also minor. Lateral rotation is normally 40 to 45 degree, and this is performed by the infraspinatus, teres minor, deltoid, posterior fibers. Medial rotation is more in comparison to lateral rotation. It is about 45 degree, and this is performed by the subscapularis, latissimus dorsi and teres major muscle. Circumduction is the movement when distal end of the humerus moves in circular motion. Coronal section, below the acromion there is subdeltoid or subacromial bursa, and in so this is the anatomy of the shoulder joint in brief, and thank you very much for your patient hearing.
Thank you, Dr. Praveen. And now, next to deliver his paper is Dr. Rajiv Anand. He will be showing us different clinical tests, a special test of shoulder.
Respected chairperson and all the delegates. So after the anatomy, it's my responsibility to come to the examination of shoulder instability. But today I'll be just covering the examination of the rotator cuff and the stability of the shoulder joint. So what we see, the physical examination of the shoulder joint consists of a test of generalized ligamentous laxity that has to be ruled out before you examine the patient, so whether the patient is having any generalized ligamentous laxity or not. Of course, we do inspection, palpation, movement, and muscle testing and special test. But I'll be focusing on muscle testing and special test in my topic. So coming to the rotator cuff, we all know that the four muscles are there, supraspinatus, infraspinatus, teres minor, and which is attached to the greater tuberosity, and the subscapularis, which is on the lesser tubercle. So testing the supraspinatus, all the movements of the shoulder joint, which this muscle is responsible. So testing the supraspinatus muscle, we call it as the empty can test, in which the patient is asked to abduct the arm to 45 degree and forward flex the arm and bring it to scapular plane. Internally rotate the arm to bring thumb down and ask the patient to lift the arm. I have pictorially shown these pictures also, and any decrease in power which indicates impingement or tear, whether it's impingement or is a tear of the supraspinatus. Similarly in infraspinatus, we ask the patient to tuck arm by the side of the body as shown in the figure and flex elbow to 90 degree and ask him to externally rotate the shoulder joint against the resistance. And pain or weakness, that indicates infraspinatus or teres minor injury. Subscapularis, we do it by belly press test, that is also called as Napoleon Bonaparte sign. We ask the patient to place both palms over the anterior abdomen without flexing the wrist joint. And he has to push the belly without flexing the wrist joint. And if there is a flexion of the wrist, there is a weakness of subscapularis. There is a Gerber lift-off test, and the patient places his arm at the back, and he is asked to lift the hand away from body. This test is done by standing behind the patient. Try to resist the movement of hand. If the patient is unable to lift the dorsum of hand away from back, then the test is positive. That shows there is weakness of the subscapularis. Though a lot of investigation, radiological investigation and other investigation has come, but still there is a great importance of the physical examination of the shoulder joint. Coming to the deltoid, we all know there it has three fibers, anterior, middle and posterior fibers. While testing the anterior fibers, we ask the patient to forward flexes the arm and apply resistance to this. By testing middle fibers, patient starts abduction. After few degree of abduction, raises the hand by standing behind the patient. For the posterior fibers, abduct the arm to 90 degree, flex elbow 90 degree, fingers facing forward, and stand behind patient and ask him to push elbow posteriorly. So if we have to stand posteriorly behind the patient and ask the patient to push the elbow posteriorly against resistance. Any decrease in power, if you get in one side, any of the test indicates weakness of the respective fibers of the deltoid. Coming to the instability, there are three instability we can have in the shoulder joint. Either it will be anterior instability, posterior instability, or there is inferior instability. So there are few tests for the anterior instability, that is apprehension test, Jobs relocation test, any bony apprehension test if there is a bony defect in the glenoid, or the posterior apprehension test, jerk test, or the inferior instability can be seen in the sulcus test. So coming to the anterior instability test, we call as apprehension test because it's a provocative test. Can be done in sitting, standing, supine, whatever you feel. Ask the patient to abduct the arm to 90 degree with elbow flexed to 90 degree. Arm is gently externally rotated to 90 degree. Further external rotation slowly we have to do, and then patient exhibits apprehension. You have to see the patient's face. If it is very apprehensive that it may come out, rather than pain, the patient won't complain of pain, but the recurrent dislocation if he has, he'll have a wide amount of apprehension on the face, and if he has pain, then it can be due to other causes, but if he has apprehension, then there will be that the test is positive. So bony apprehension test is present in lower ranges of abduction and external rotation. If there is any glenoid bone loss, you can have these tests positive. That is the same apprehension test with a low range of abduction and external rotation. Jobs relocation test, the patient lies supine and place arm in 90 degree abduction and full external rotation, and the patient feels apprehension. Now with the other hand, you press the shoulder joint anteriorly. So that while pressing the shoulder anteriorly, we are relocating the joint again. So the apprehension wanes off. The patient will not have apprehension, and as the head relocates, apprehension will decrease markedly. So remove this posterior force now without indicating the patient. Then the apprehension reappears. So that is Jobs relocation test. Posterior instability, though the posterior dislocation is little uncommon, so but the patient in sitting position, ask him to relax, then adduct, ADD, adduction, and internally rotate the arm with elbow 90 degree flexed, and if the patient is having apprehension, then he has posterior instability. Similarly, the inferior stability, It's done on the sitting position, stand behind the patient, and examiner pulls the elbow down and observes the acromion. You can see the mark on the shoulder acromion. If there is a gap on lateral aspect, you'll see a sulcus, a depression, a gap, and if it's visible, it denotes inferior laxity. Other instability test is anterior drawer test. The patient lies supine, and if the left shoulder has to be examined, examiner holds the affected limb in his right axilla, shoulder abducted to 80 to 100 degree, 20-degree forward flexion and externally rotated. Examiner then holds the proximal humerus with his right hand, gives counter pressure over the coracoid process with the left thumb. Now he gives anterior translation with right hand. Normally, more than 50% of head should not come out glenoid cavity. Always compare with the other side, then this test is positive. Rockwood test is for anterior instability. Patient in sitting position, arm tucked to the side of the body and externally rotate. If it is repeated at 90 to 100 degree, 120 degree, and if the apprehension is positive at 45, 90 and 120, then test is positive. Thank you very much for your patient hearing.
Any question from the audience? May I ask a few? I think.
Yes, I have one question.
Huh?
सर हो गया, 3 बार हो गया, 4 बार हो गया, अगर वो है तो इसमें से कौन सा टेस्ट करना चाहिए?
Now, where patient is complaining of recurrent dislocation, you don't have to do. I think you don't have to do anything. It is crystal clear. He has got instability. The tests are done where you are in doubt. Patient somehow feels all of a sudden, particularly players, arm goes dead. What is that? There these tests, and not only one test. There should be cluster of tests. And their clusters are already defined. Not one, no test, there are more than 200 tests are there. Eponymal tests. And there is a jungle of it. You may be lost. So they have devised cluster of tests. As for impingement. So basically, what you call arc test plus drop arm test plus infraspine. If all these three are positive, then you're sure that there is impingement. 85 to 90% chances are there is impingement. Remove it and add Hawkins. This is for rotator cuff. Remove this, add Hawkins. Impingement test, almost positive. Or, of course, you have to get it confirmed by, MR or
But
USC.
even in the recurrent dislocation, sir, definitely the MR shows everything very crystal clear. But instability, whether he is having a posterior instability or the inferior instability, that has to be checked clinically. So while you are performing the surgery, you must know whether there is a inferior laxity or if there is a posterior instability. So if you are sure about that, this is anterior dislocation, recurrent dislocation. So the surgeon has these things in mind, so that gives a good things to him.
And one thing I would like to add, by the side, if you are doing this test, basically everybody now agreed upon that. This is for basically only infraspinatus. The moment you lift it to 20 degree, it becomes for all three. And then here, that is all, what do you call that, drop arm test, that is for teres minor.
Teres minor, yeah, they have divided into different muscles.
Of course, you have to keep all other muscles silent. So in these positions, all other muscles are basically silent. Only infraspinatus is active. The moment you lift it up to 20 or 30 degree, supraspinatus also comes into action. Here, this is basically for minor.
Abduction, yeah.
And some say from empty can, better is full can.
Full can is also, yeah, because I only focused on the specific important test which you can assess, Definitely, sir has said that the infraspinatus is definitely a very strong internally rotated, internal rotator, So that
My
you have to,
one question, as far as the arthroscopy surgery is concerned, really this test is very much relevant when you put a arthroscope in the shoulder, an examination of the shoulder before surgery. So, do you think that the arthroscopic visualization inside the joint that actually match with the examination, it is important examination relevant with arthroscopic examination? I think that this is the two different kind of situation. Might be examination is okay
Something
and
different as
arthroscopical is a different. So do you tell me a single test by which we can realize on this, this is the okay. There's so many tests, but as far as the instability is concerned, which test is more relevant with our arthroscopic surgery? Not
definitely,
so many tests.
the anterior instability test, which if you are clinically getting it, so definitely that will confirmed by your arthroscopy that definitely is instability is there, so that we can do that. Anterior
May I-
instability test is important.
May I? Majority of instability is anterior. That is for sure everybody should be agree, majority. And there is three in one test. Apprehension, relocation and release. If three are positive, you are dead sure there is a problem anterior instability. And there is a very easy to just put your, release it. Apprehension,
Yeah.
relocation, release. Sure.
Sir, any comment by IPS sir?
No, I think your question is very important regarding the clinical examination. Even if there is a frank dislocation, we have to do at least 2 or 3 tests. Number one test which is important is in a patient which is slightly older age group, dislocations would happen not due to labral injuries but due to rotator cuff tears. So checking the rotator cuff power is very important
Important.
if this is there. Number two, as rightly said by Rajiv, that whenever instability is there and you think it is an anterior instability, no doubt about it, but often these patients are multidirectional unstable.
Yeah.
They are predominantly anterior instability, so you have to actually do the posterior jerk test to see for posterior instability and sulcus sign to see for inferior instability and also see for laxity of the other joints, because these patients might have a subtle MDI. So when you do a Bankart repair, you should always think about a posterior labral lesion or a capsular plication, which is also important. Yeah.
Thank you, Dr. Rajiv.
Generalized laxity, if it's there, so does it affect in your surgery, like to do something else also, or only
Yes,
the Bankarts?
yes. So if you have a generalized laxity, which are symptomatic, and patient also has a dislocation episodes, 1 or twice, primarily anterior, and on an MRI you see a Bankart lesion. So in addition to a Bankart repair, you also do a pan-capsular plication, like the typical capsular shift, which Needs used to do. Open Needs capsular shift, you do capsular plication to take care of the
Other
instability.
laxity.
Yeah.
Thank you so much, sir. Thank you, sir.
Next speaker, Dr. Shikha Rani. Her topic is radiological evaluation. Shikha Rani.
Pranam to all my seniors and a very beautiful good morning to my juniors and my colleagues. So my today's presentation is MRI of the shoulder joint. As already said in detail about the anatomy part, we are concerning here about the rotator cuff and the labrum. As we all know, the rotator cuff consists of the 4 muscles. From the scapula, it is subscapularis, and from posteriorly supraspinatus, infraspinatus, teres minor. The 3 muscles, that is supraspinatus, infraspinatus and teres minor, which attaches on the greater tuberosity. So while going to the MRI part, we will focus mainly on the rotator cuff tendon and the labrum. Since the cavity is very small, so the labrum, which is a fibrocartilaginous structure, which provides stability to the joints. Like any other joints in the body, here we will see the same thing again and again. This labrum is a triangular part. Now the technique of the MRI. In MRI, the Maggie has already classified that the MR arthroscopy is far better than normal MRI. So the MRI technique, the patient is in supine position with the hands lying by the sides and in slightly external rotation. We take mainly in the 4 planes, the cross-sectional study, starting from the axial plane, from the coronal oblique, sagittal oblique, abduction and external rotation. Sequences are very important because for the degeneration to the frank tear, the different sequences are in used, but it depends upon the faculty that which sequence and at which position, whether it is coronal oblique or sagittal oblique, he feel comfortable to locate the tendon or any ligaments. The low TE sequences are T1, PD, usually PD is non-fat saturated, GRE, and the main part is the T2 to look for the fluid and increased hyperintensity. Slice thickness normally 3 to 5 millimeter, FOV is 160 into 160. Now the axial plane. From above to downward, the sections are taken. From above, it will start from the acromioclavicular joints. And as we go below, the time to time, the different structures will come into the plane. The one thing is that the muscles fiber look hyperintense relative to the hypointense structures like tendon, ligaments, labrum, and the fluid. If the patient is in pain or any tear, then definitely there will be fluid. If less fluid, then MR arthroscopy, which will create the distension to locate carefully the different structures. Now from above, superior glenohumeral ligament, as the sir has already told, the 3 glenohumeral ligaments, superior, middle and inferior. We are seeing here in the coracoid. According to the spine, the above to the spine is supraspinatus and below the spine is infraspinatus muscle. In the rotator cuff, as you know, teres minor has a very less role. Now superior glenohumeral ligament, here we can see the labrum, anterior labrum. Labrum tear is very important to look for, and infraspinatus tendon. Again the bicipital tendon, which is biceps, is very important. It is seen in the bicipital groove. The middle glenohumeral ligament is just anterior to the anterior labrum. And here middle glenohumeral ligament and inferior glenohumeral ligament are seen together in the axial plane. The axial plane is very important to look for the labrum. Now the coronal oblique. The coronal oblique plane is just parallel to the supraspinatus tendon. In fact, the supraspinatus tendon must be in parallel to the supraspinatus muscle. Tendon, as already I told, that the tendon will look hypointense. In the coronal image, we take the images from the lateral to the medial aspect. From laterally, the whiter part is, as you all know, the white outside is the fat. And again, inside, from outside to inside is the deltoid. Under the deltoid, there you can see the supraspinatus muscle, infraspinatus muscle and all the rotator muscles. Here we can see the coracoacromial ligament. Since the coracoid is attached with the coracoclavicular, coracoacromial and coracohumeral ligament, all the ligaments look hypointense. And in coronal view is very important to look for the supraspinatus muscle tendon. Here you can see beautifully the supraspinatus got attached on the greater tuberosity. And on the greater tuberosity, any tendon tear will start from the greater tuberosity and it will go up to the critical zone, which is 1 centimeter from its attachment. So this section is very important. Keep this in mind. This is the coronal for the supraspinatus tendon. And now the infraspinatus tendon, which is also attached on the greater tuberosity, axillary recess bounded by the inferior glenohumeral ligament. Now the sagittal image. In sagittal image, you can see the supraspinatus, infraspinatus and the coracoid. This longitudinal structure is coracoid and subscapularis muscle. The glenoid fossa, sagittal image when we take, it is just perpendicular to the supraspinatus muscle. So in the middle section, as we go in the sagittal image, from lateral to medial, the infraspinatus tendon and teres minor. At one section, this is the section where inferior glenohumeral ligament and all the tendons are seen over here. Now, ABER abduction and external rotation, which is important for the labral tear and the rotator interval. Biceps tendon, you are looking very nicely over here. At greater tuberosity, all the attachment site of the tendons. Now, in normal MRI sequence, as already told, for the low TE sequences, for the degeneration, PD sequence is very important. Now, the magic angle phenomenon is it's a 1 centimeter from the site of attachment of the greater tuberosity. It looks hyper intensity. And rotator cuff tear, you can see the fluid in any tear. What you are asking to the radiologist, that you tell me about the tear, what is the depth of the tear and where are the tear fibers. If the fibers are located just medial to the glenoid, it means it's very hard to repair. The rotator cuff, the partial thickness, and here the two player which has already suffered from rotator cuff tear. One is Srinath and another, nothing to mention. Can anyone say who is she? Yeah, very good. This is Rembrandt tear at the greater trochanter. Dimension of the tear in partial thickness and full thickness, according to that, 1 centimeter, 1 to 3, 3 to 5. And for any tear, whether it is partial thickness, because the total depth of the tendon is 10 to 12 millimeter. This is tendon retraction which has already retracted up to the glenoid. And now the labrum. The labrum is already divided into superior, inferior, anterior and the posterior. As you go for the abduction and external rotation, this labral tear is beautifully delineated. This is slap tear. Sachin Tendulkar has already suffered from this slap injury, and it is sublabral recess differentiated. Any tear, you will see the irregular margin, hyper intensity, and there will be fluid intensity. T2 weighted images will show the hyper intensity for any tear, Bankat. And last but not the least, he has not suffered from this rotator cuff tear, but actually in practice for the last 2 years for this movie, nothing to mention, again for the instability. Thank you so much.
No.
Thank you, Dr. Sikharani. Now I invite Dr. Vidyasagar to kindly deliberate on patient positioning.
Thank you, sir, dignitaries. So shoulder arthroscopy is not uncommon now. For last 2 decades, it is going to be very common. So after anatomy and radiology, now coming to anesthesia and patient positioning. So basically, there are 2 principal positions. One is lateral decubitus position and another is beach chair position. So some surgeons are comfortable with lateral decubitus position and some surgeons are comfortable with beach chair position. So I am going to discuss about the both and pros and cons of both the positions. So coming to lateral decubitus position, in this position, the affected extremity is upside. Head is well padded and chest strap is done, and all the bony prominences are well padded. And the head is, limb is upper extremity basically is attached to a suspension device, and the surgeon lies posteriorly. So Gross et al. Modified this lateral decubitus position. In this modified lateral decubitus position, there is posterior tilting so that the glenoid comes parallel to the floor. So what happens with this position? There are few advantages of this. There is inferior glenoid labrum becomes more visualized. So coming to advantage of decubitus position, it is safe positioning. And in the beach chair position, there are few complications that may occur, that will be discussed later on. Joint dissection is more as head is hand is suspended. So there will be more joint dissection. Better access to posterior shoulder as it is 180-degree visualization. So coming to disadvantage, neuropraxia from the traction may occur. Sometimes it has been seen that superficial radial nerve, or in few cases median nerve has seen to be neuropraxitized. And coming to beach chair position, so in this position, after anesthesia, the hip is flexed to 30 to 40 degree for sciatic nerve, and knee is also flexed 30 to 40 degree, and the head is held with some maneuver, and the affected limb is positioned like this with the limb positioner. So what are the advantages of this beach chair position? So when we have to convert in the open surgery, so it is easier to convert this open surgery, and faster and easier patient positioning after anesthesia, reduced risk of anesthesia that may occur in lateral decubitus position, less distortion to intra-auricular capsular anatomy, but the major disadvantage is cerebral hyperperfusion. Basically what happens, we want our surgery, we want BP of the patient is 90 to 60, and already there is compromised and cerebral hyperperfusion may occur that may lead to brain stroke and death. Another disadvantage is failure to position the neck in neutral position. If the neck is hyperextension, then cranial nerve injury may occur. If the neck is in hyperflexion, then spinal cord ischemia may occur. So equipments are expensive. So what the literature says about this, both the positions. So this literature was published in Orthopedic Joint Sports and Medicine, published by Paul et al. In last year. So he reported that both the positions have both the positions, and there was no significant difference in demographics between the groups. Another literature published by Frank et al., in which this meta-analysis was published few years back, and he examined around 400 shoulders, in which 2200 shoulders in the beach chair position and 1500 around the lateral decubitus position. And both positions provide the excellent clinical outcome with low recurrence rate. So to summarize, surgical positioning for arthroscopic shoulder surgeries don't significantly affect recurrent stability complications. Both positions are provide good outcomes, and it depends on your training and you're comfortable with the ease. Thank you, sir. Thank you.
Thank you, Dr. Vidya.
Sir, my question.
Huh?
नहीं हो गया sir.
Okay, na?
हाँ.
So now with this we come to end of this session. Any question from Dr. Vidya?
You prefer beach chair or lateral decubitus? Always, sir. Oberoi, sir. Always. Okay, sir. Thank you. Sir.
Now, may I request our chairman to give a memento to our speakers, requesting President sir and Samir to cordially give it to them. Praveen, please come to the dais for the podium. Rajiv, Shikha. Shikha, just wait. To none other than Mr. BOA. Request Shikha, please. Very nicely and very articulated presentation of yours. And Vidya, Dr. Vidya, requesting Dr. IPS Oberoi sir to please give a memento to our chairpersons. One to Dr. Ranjit sir. And another, please. Thank you very much. Now we will have a very short inauguration program for this meeting. Rajiv, to take care.
Again, good morning to all of you. So we have a very short inaugural function. So we'll start with that. I'll request our President, Bihar Orthopaedic Association, Dr. Ranjit Kumar Singh, to please come on the dais for the inaugural function, sir. I request our three eminent guests, Dr. IPS Oberoi from Delhi, to come on the dais, please, sir. Dr. Deepak Joshi, also from New Delhi, please come on the dais. Dr. Sandeep Singh, very active that he went to Gurdwara at 5 o'clock in the morning, please come. Our Secretary, Bihar Orthopaedic Association, Dr. Mahesh Prasad, to come on the dais. And our very good friend, Dr. Rakesh Chaudhary, the organizing chairman of this show, please come on the dais. And Dr. Atal Bihari, organizing secretary, to come on the dais, please, sir. The President, Bihar Orthopaedic Association, and all our eminent guests on the dais, please come and join hands by lighting of the lamp.
तुण्ड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा वक्रतुण्ड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा वक्रतुण्ड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा
सिंदूर लाल चढ़ायो अच्छा गजमुख को चोंदिल लाल विराजे सुत गौरी हर को हाथ लिए गुड़ लड्डू साई सुरवर को महिमा कहे न जाए लागत हूँ पद को जय देव जय देव जय जय जी गणराज विद्या सुखदाता धन्य तुम्हारो दर्शन मेरा मन रमता जय देव।
So now I will request our President, Bihar Orthopaedic Association, to give a token of love and respect to our all those three national eminent guests. So may I call upon Dr. IPS Oberoi to please come and give a moment to him. Dr. Deepak Joshi, please. And I'll ask our Secretary BOA to come forward and to join it and to give a memento to Dr. Sandeep Singh. So now I'll call upon our President, Bihar Orthopaedic Association, to say a few words about this shoulder arthroscopy conclave, including the life surgery. Our BOA President, Dr. Ranjit Kumar Singh.
Good morning. Namaskar. I am here again standing before you, welcoming you, and I really feel very proud to have you all this morning in this CME on arthroscopy. As we all placed to ourselves in GB Bhagalpur to have CMEs of our own, that is of BOA, by the BOA, of the BOA, for the BOA. And continuing with the same pitch, we have already completed or done two very successful CMEs, one on rheumatology and one on acetabular injuries. Arthroscopy is an evolving branch. We couldn't learn, but we want our youngsters to learn, and that's why we have invited eminent faculties from Dr. IPS Oberoi, Dr. Sandeep Singh from Bhubaneswar, and Dr. Deepak Joshi from Delhi. Along with that, our own faculties of national repute are also involved so that you can learn the basics as well intricate nuances of this surgery. Knowledge is an ongoing process. Whatever you know that I know fully is never a truth. Anything, there must be something lacking, and by interacting with each other, we can add to our knowledge. I think by inviting these people, I would call them all alchemists so that they can improve the metal, convert the metal to gold or silver, whatever is there. Thank you. Wish you a very happening and knowledgeable session throughout the day. Thank you.
Thank you, President sir. We would love to hear from Dr. IPS Oberoi. Please come and say a few words to our young and arthroscopic surgeons.
Hi, good morning. Thank you very much for inviting me to come to this beautiful meeting. I see so many familiar faces, and it's always a good feeling to come back to Patna again. We did a live surgery course couple of years back, and then many years back a live surgery even at PMCH for the ACL reconstruction. I think shoulder is something which is still evolving all across the world. We see a lot of shoulder patients, especially Bihar, which are coming actually to Delhi for treatment. And I think it is right time for the local orthopedic group here to learn the tricks of arthroscopy surgery and propagate it. A huge amount of heavy laborers are there which have shoulder problems, especially rotator cuff and recurrent instabilities of shoulder. And the more you start examining them, the more you will realize that shoulder is actually a big subspecialty which needs to be developed. Courses like these definitely help you to upskill the teaching and learning. We will do some live surgeries today, a bank cut and a rotator cuff, and just go through step by step of how exactly to go ahead and do it. Believe me, they are not difficult surgeries to do, but just the learning is something which will take some time. So if you are consistent on learning, doing some cadaver labs, attending live surgical courses, 6 months, 1 year is a good time to you to learn the skills of shoulder arthroscopy and shoulder treatment. So I welcome you again to this August meeting and hope that you will learn today. By end of the evening, you will have at least some points of learning which will take you back home and help you in encouraging yourself to learn shoulder more and more. Thank you very much.
Thank you, sir, for your enlightenment to our young arthroscopic surgeons. So may I invite Dr. Deepak Joshi. He is in the Sports Center Safdarjung Hospital to say a few words.
Thank you, sir, and thank you all the organizing team and president, sir, and for inviting me to this meeting. And I see lots of young faces, as Dr. IPS Oberoi has said. So shoulder arthroscopy, anything is not difficult when everyone can do anything, but definitely it has a little bit a learning curve, and it's a good opportunity for all the youngsters to see how the shoulder arthroscopy is done. The two common procedures in the shoulder arthroscopy, that is the Bankart and the rotator cuff, these are the two most commonest of them, and you will have an idea about how they are done in a stepwise manner, and I think it's a good opportunity, and you can go to the cadaveric labs now. Earlier the cadaveric labs were not used to be there, only a few centers was doing. Now it's, I think it is very commonly done in so many places. You learn there and learn the skills, and I think as IPS said, lots of patients come from this region to Delhi, and I think if the you people start doing it, we'll also have less load, and you will also do well. Thank you so much.
Thank you, Dr. Deepak Joshi. And now may I invite our young arthroscopic surgeon, Dr. Sandeep Singh, to please say some few words. He is from Bhubaneswar.
Thank you very much. So actually, when it comes to Eastern India, like the eminent dignitaries have already said, in Eastern India, shoulder arthroscopy is actually picking up. And when I started my practice, I saw most of my patients would actually come and question us that, can we do it here? Should we do it here? Now that is something which needs to change in my eyes. Eastern India has a lot of talented surgeons who just need the platform to learn the skill of arthroscopy and to propagate it further. Now when it comes to shoulder arthroscopy, like Dr. Deepak Joshi said, there is a learning curve. There is a definite learning curve, but once you have a learning curve which is guided by proper education and proper protocols, there is no reason why, like if I could read it, then everybody else can. So there's a learning curve when it comes to any surgical procedure, but when it comes to shoulder arthroscopy, the caseload is huge. We regularly see a lot of Bankarts, a lot of rotator cuff, a lot of undiagnosed rotator cuff injuries, and people continue in suffering because the examination is not proper. So I think through the end of this course, we just hope that sir is doing a Bankart and the sir is doing a rotator cuff surgery. So we will try to take you through the steps of the surgery, how the protocol should be followed post-surgery, and what are the materials which are used during surgery. So hopefully it will be a good educational session for all of you all. And if you have any questions, we'll be very happy to help you with them. Thank you very much.
Dr. Sandeep Singh. So may I request now our Dynamic Secretary, Bihar Orthopaedic Association, Dr. Mahesh Prasad, to say a few words.
Good morning, everyone. Now the Bihar Orthopaedic Association started a new thing, arthroscopy workshop today. And we are delighted over here to have a three dynamic legend among us, Dr. IPS Oberoi, Dr. Deepak Joshi, and Dr. Sandeep Singh. And he is very much experience about this technology, and I must say this credit goes to our whole department of PMCH, all faculty, Dr. Bharat Singh, our HOD, and all faculty, Dr. A.K. Manav, Dr. Rakesh Chaudhary, Dr. Rajiv Anand, and many more assistant professor and resident, and all PG. They all are enthusiastic to have such kind of academic activity. Arthroscopy surgery in our days when I was a student, just I heard the name of arthroscopy surgery, and that moment it was not so familiar that I today you see. And first, I have an experience about arthroscopy by our most legend, Dr. IPS Oberoi, where he worked on the Railway Hospital, New Delhi. So I have an interest in arthroscopy, but at that moment, it was not so easier to learn anything. But nowadays, it's more familiar to all of us, and our postgraduate student very much enthusiastic about how to do arthroscopy surgery. Now first start with the knee arthroscopy. Gradually it developed shoulder and other, today elbow, hip, and many arthroscopy examination and surgery. But one thing I would like to say that arthroscopy surgery is not so common as knee surgery. So shoulder is a little bit tricky, but we have a legend like IPS Oberoi and many more faculty, and of course we have its own faculty in our state. They are doing very well. in arthroscopy, and we have learned a lot from him, and we experience their technique to all of us. I must say the arthroscopic technology is different. This is the indirect kind of surgery, not a direct surgery. So you must know the thing very curiously and very seriously by our legend. Two shoulder surgery, one is Bankhart's repair and another is rotator cuff injury, and they have explained very, very sensibly, and you must look of this, and must thanks to all our delegate to participate in this workshop, and I hope it will worth memory to all of us. Thank you very much.
Yes, now I'll invite our organizing chairman, Associate Professor of Orthopedics, Patna Medical College, to come and say a few words and a vote of thanks.
Good morning, everybody. It's have been my pleasure to see you all here this morning. When we discussed with our President and Secretary, Bihar Orthopaedic Association, about doing a workshop or a CME on arthroscopy, I really wanted to have some live surgery lectures, gives you the knowledge, what you need, the nose, but really the live surgery and the skill labs tells you how to do it, and you always learn more by seeing a live surgery or performing on a skill station. You know what the problems can crop up. Lectures are given right for the good things, but what problems come up when you are really during the surgery, it can be learned from while you are seeing the live surgery. I just wanted to keep it mostly for the young people who wanted to learn, interested in shoulder arthroscopy and other arthroscopy, to look and have some curiosity and develop a passion for these things. I really thank at the outset our President and Secretary of Bihar Orthopaedic Association, who have been with me all the time, helping me out with all the things. Our all three visiting faculties who had really been so kind to come, give their valuable time to make us learn something. Our dear friend, Dr. Rajiv Anand, all the delegates and the sponsor to making this very successful program. And we hope that all of you will enjoy and learn something out of this, so that if you are not started doing it in couple of months, you should start doing it. Thank you very much. It was a good one.
Thank you.
इसको परसों सुना रहा था मैं, है क्या कि पढ़ना लिखना जानना एक कंटिन्यूअस प्रोसेस है। बहुत बार जिन चीज़ों को हम समझते हैं कि हम समझ रहे हैं, उसकी बहुत सारी बातें हम नहीं जान रहे होते हैं, और विद अपने लोगों के बीच इंटरेक्शन से। तो उसी में मैंने कहा कि मैं एक अमीर खुसरो की दो पंक्तियाँ बोलता हूँ। जिहाल मस्किन मकुन तगाफुल, दुराए नैना बनाए बतियाँ। अब आपकी दूसरी लाइन आपने समझ ली, दुराए नैना ब्रजभाषा में है, पहली लाइन नहीं समझ पाए, बात भी पूरी समझ गए, क्या कहना चाहता है ये। तो आपको पर्शियन सीखनी पड़ेगी, क्योंकि पहली लाइन पर्शियन में है, दूसरी लाइन ब्रजभाषा में, हिंदी में है। तो अर्थ तो जो इसका है मैं बता दूंगा, लेकिन जब उसको भी समझ जाएंगे कि अर्थ क्या है, तो आपको लगेगा कि समवन इज टॉकिंग टू हिज बिलवेड। बट फैक्ट ये है कि जब आप अमीर खुसरो को जानेंगे, तब समझेंगे कि वो तो ऊपर वाले से बात कर रहा है। So that is the idea of knowing. Thank you.
Thank you, sir. So end of the session, I will start the next session, and after this session, the live surgery will start. So may I call upon Our chairperson, Dr. Ritesh Runu. Dr. Ritesh Renu to come, and Dr. Mahesh Prasad. Dr. Mahesh Prasad to chair the session.
After having a good session on the basics of arthroscopy, I request you all to kindly have tea and take your chair. We are going to start our second session. And our first speaker is Dr. Rakesh Kumar Chaudhary. Sir will be talking about introduction and use of radio frequency in arthroscopy. So I request all the delegates to kindly have their chair with tea in their hand.
Right, good morning, Mr. Chairman says. We know while doing the arthroscopy in shoulder knee, it is quite easy that we put on the tourniquet there and then we start the surgery. Very clear, bloodless feel we can achieve at all the time. But the shoulder, the problem is it is a tight joint surrounded by the bony tissue, capsule is small, and once it starts to bleed, you really can't do anything and you have to just wait for the things to clear up. And so this RF device, radio frequency device, the coblation device has come a very handy thing to us while doing shoulder arthroscopy. We should understand two terms, electrocautery and electrosurgery. Electrocautery, if the current does not pass through the patient, and electrosurgery, when the electric current passes through the patient somewhat, whatever distance is traveled, doesn't matter. In electrocautery, whatever it says, there is a wand which is heated by electricity, the electricity doesn't pass, and it just burns the tissue there. The burning causes all the tissue to be destroyed there, so all the vessels are dead and tissue is dead. The problem is that you kill a lot of surrounding tissue. Then comes the monopolar device. The active electrode is located on the surgical instrument. The return electrode is the grounding pad, we all know, is under the patient somewhere. The generator directs the current from the active electrode through the patient body to the patient and to the returning generator, and we can good. Then bipolar, a forceps-like thing, same thing. From one pine, the current passes through to the other pine and back to the generator. And there are also modern bipolars that works at a very lower temperature, and both the terminals are there on the same band. Now the principles of radio frequency. We know that if alternating current that is in their household at 50 hertz with low voltage 220 volt, when passes our body, we get a shock, electric muscular contraction, and a very high voltage, even at 50 hertz, say 11,000 volt, it passes through our body, we get electrocuted. All our thing, whole body is burned. But if the current at low voltage passes through a very high cycle, that is 330,000 cycle, 330 hertz per second, the electric current will pass through the body harmlessly. You won't even know the electric current passing through your body. So, a radio frequency device that we use operates at on the basis that it generates high frequency, that is almost 500 kilohertz. Again. Sorry for the delay. set kar do. Oh, sorry, yeah. So, in radio frequency device, a very high frequency voltage, low voltage, almost at 500 kilohertz, which is brought close to the proximity of the tissue and causes flow of electric current through them. The tissue itself provides necessary impedance to the electrons to overcome resistance and produce heat in the tissue, which become hot enough to vaporize. There is no burning of the tissues. And what happens that the circulating blood quickly dissipates the heats away. So even the temperature rise is minimal there. So, but again, if you come down to arthroscopy, it is even better. What we are using is a technique called coblation. It is a controlled ablation, what you call. Coblation operates as a very low temperature that than even other RF technology which we are using in surgery and gynecology. And it works on the basis of forming a high energy plasma from the electrolyte based solution. So how it works? The tissue ablation, coblation means precise volumetric removal of the tissue. When you compare the ablative mode and the hemostasis, what electrosurgery means, that it works as a very low temperature, collagen fibers shrinks within the tissue when heated, and there is hemostasis of blood. So comparing here, you can see the conventional electrosurgery produce almost 400 degree of temperature, while the RF based device produces just 40 to 70 degree. The articular surface, articular cartilage is very sensitive to heat. If you use normal electrocautery there, it will get burned. Even if you don't see at that time, after a couple of months, if you do MRI, you will see dead cartilage there. So benefits, a very limited depth of thermal penetration, hardly less than 0.1 or 0.2 millimeter of destruction is there, minimal collateral tissue damage, localized effect, controlled volumetric removal, and surface tissue temperature is very low. So the various kind of bands are available which you use for various surgery. It is almost surgery specific when you use and what you use. There are a few safety tips that you use. Keep electrode surrounded by irrigation fluid. Never bury electrode into the tissue. Never activate electrode in the air pocket. Keep electrode in full view. And good irrigant fluid removes heat from the tissue. Where RF can be used, it can be used in shoulder, knee, elbow, wrist, ankle, anywhere. In shoulder you can do all these surgery, almost any surgery you do, and it was really for the shoulder, and after it's so much function, even the surgeons are now using it in knee. You can use it in ACL debridement, lateral release, meniscectomy, any surgery you do, you can use it in all of them. So you can very precise incision to the lateral capsule. You can do meniscus balancing by this. You can do chondroplasty, removing all those loose cartilage without damaging the normal cartilage. This is the beauty of this. You can use it in small joints. The benefit is that it quickly debrides the tissue because the visualization is limited. The volume is very limited on small joint, and you have to do your surgery there. So it gives excellent visualization, and small malleable electrodes are there. In small joint, you can use it for synovectomy, cartilage debridement, thermal modification, any of things. A very short video of its working acromial decompression taking place. ये नहीं है, pointer नहीं है. You can see a glow there, which I will tell you. क्या हो गया यार? हो गया खत्म. You can see something glowing up here, and this getting brownish discoloration, and the tissue are removed in millimeter by millimeter, even less, 0.1 millimeter in a thing. You can do very coagulate, no bleeding. All the bleedings can be stopped there. This is the case of when frozen shoulder, when you use a very tight joint, so even the fluids are less. High synovial thickening, it all causes problem in your visualization. So you start, you can see we remove it by this band here. Then you release the capsule, just the capsule. From above downwards, you can see the muscles there. If there is a bleeding, you can just coagulate with, do hemostasis with the same band at the same time, and then again the visualization is very good. So, a typical question that could be asked, if the RF, I show you that it glows, if the RF band tip is glowing, am I burning the tissue? No, the glow signals that the band is working correctly. It is not a heat indicator. A yellow color indicates the presence of excited sodium atoms from the NaCl based saline which you use. Various atoms have its own color. Again, does the saline around the RF band tip get hot? Very minimally. Energy from the generator is used to ionize the saline in the very thin layer around the certain region of the active electrode. Much of the saline near the band tips remain below the 40 to 70 degree, and also since you are using a lot of water and the suction is there in the same band, even less, very quickly the things dissipates. Again, if the RF band is not heat driven, why does the soft tissue sometimes turn brown? You will see it turns brown. And when we think that it is burning it, the tissue turns brown due to oxidation, similar to an apple core exposed to air after apple have been eaten. सेब खा करके आप टेबल पर रख दीजिए, it becomes red. It is not burned, it is oxidized. Similar is something happening there. So these are the, how much cell necrosis occurs in tissue not targeted. How much depth? Confocal microscopy indicates that the depth of cell necrosis at the treatment ranges from 100 to 250 micrometer, less than 1 millimeter, 0.1 millimeter, used with RF device used by 7 It's very minimal collateral damage. So all the benefits are there while using RF device. Have to, a bit expensive, the bands are expensive, but it is very useful device. So I just wanted to introduce you all. Thank you very much.
Thank you, Rakesh. Question from the audience? No one. So one question from my side. What is the basic difference between the RF and bipolar cautery, and how it's beneficial over the bipolar?
In electrocautery, there is basically we deal with the current. The current passes through one tine to the other, one pole to the other through the body. Even if you use bipolar, it goes from one tine to the other tine. Here in coagulation, what we use, the current just breaks the sodium and chloride into two parts, and the energy develops there, so much of energy that there is a plasma formed around. That energy creates a plasma which bursts the tissue into very tissue next to it. So that is the reason there is no burning there, nothing there. Even in RF which we use, it is the same thing happening. It is the coagulation which create a plasma and make it tissue very vaporize there.
Thank you. Thank you. And I would like to invite our next speaker, Dr. Gurudev Kumar, and he will speak on portal placement in shoulder.
Good morning, everybody, respected chairperson. My topic of presentation is portal placement for shoulder arthroscopy. So, in the morning session, we have already learned about the anatomy, radiology, and positioning during the for the shoulder arthroscopy. So now we're moving the next, how to create the portal for the shoulder arthroscopic surgery. It is the foundation stone for your future planning of the surgery. So before going to create a portal, we are going to do the anatomical bony landmark before creating the portal. So we start from the posterior side, the spine of the scapula going laterally. This is the posterior lateral corner of the acromion. This is the lateral border of the acromion, and this is the anterolateral border of the acromion. Then come towards the medially. This is the clavicle. This is the anterior acromio-clavicular joint, and this is the V-shaped. This is the area over the superior aspect of the shoulder, and this is the navicular notch. It is bounded by anteriorly with the clavicle, medially, laterally with the acromion, and the posteriorly by the spine of the scapula. And don't forget to mark this coracoid process, and this is the ligament, coracoacromial ligament, and pass a line through this coracoid process. So any portal lateral from the coracoid process to the 5 centimeter from the lateral border of the acromion, come to the posteriorly. These are the area where we can create the in number of portal without any disaster. So the posterior portal, this is the first viewing or working portal for the shoulder arthroscopy. It is created at the posterolateral border of the acromion, 2 centimeter inferior and 1 centimeter medial to the posterolateral border of the acromion. So make the skin incision with the 11 or 15 number of knife, and then introduce your scope directed at the coracoid process. So in the adhesive capsulitis, you feel there is some resistance while passing the trocar or sheath inside the joint. There is, because there is the thick capsule, and in multidirectional instability there is thin capsule. It is easy to penetrate inside the knee joint, shoulder joint. Sorry. Then once you introduce your scope, then we can see directly the biceps tendon, which is the first structure visible after putting the scope inside the shoulder joint. So the anterior portal, the extender anterior portal lies anywhere inside this rotator interval, bound by the biceps, then the subscapularis, and medially by the glenoid or the humeral head. In rotator cuff surgery or the biceps stenosis, the portal is directly lies in the center of this rotator interval. But when we are going to address the instability cases, then we have to create 2 portal, the anterosuperior portal and the anteroinferior portal. The anterosuperior portal, it is just lateral to the acromion process in the line of the coracoacromial ligament. So it makes by the outside in technique with the 80 number needle, and viewing through the posterior portal with the scope, and the needle should pass directly anterior to the biceps tendon. Here in this region your needle should be passed, otherwise it leads to the crowding of the cannula. So you take this spinal needle, and with the thumb or the finger we can palpate the pulsation where we are going to introduce, and this is the site for the anterosuperior portal. Then coming to the anteroinferior portal, it is located, see, suppose this is the biceps tendon, and this is the glenoid, and this is the subscapularis. So at the junction of biceps and the subscapularis, your needle should your needle should pass, and then before creating this portal, we have to check whether we are going to achieve this the inferior margin of the glenoid. And this is the two portal, antero-superior and the antero-inferior portal, and there is keep 1 centimeter of gap between this portal, otherwise there is overcrowding of the cannula. And this is the very important portal, working portal for the addressing the instability cases. Then coming to the lateral portal, it is located 1 to 2 centimeter distal to the distal edge of the acromion, and its portal passes through the deltoid muscle. Again, it created with the outside in technique by putting the scope through the posterior portal inside the subacromial space. And this portal is basically used for rotator cuff surgery and the subacromial decompression to increase the space for the rotator cuff and in impingement cases. Then the navigator portal, in the superior aspect of the shoulder joint, press with your thumb, there is soft spot, and the portal is just medial to the medial border of the acromion, and it passes through the supraspinatus muscle. Its function is to address the anterior glenoid visualization, slab repair, and the suprascapular release. The modified navigator portal, it is located little bit more posterior and medial to the navigator portal. It is more medial and posterior from the acromion and the spine of the scapula. The better angle of anchor placement and the rotator cuff repair. And the modified navigator portal is better than the navigator portal because here it entered through the supraspinatus muscle, so the chance of subscapular nerve injury is less. Then the posterior lateral portal of port of Wellington, it is just lateral or anterior to the 1 centimeter to the posterior lateral corner of the acromion. No cannula is pressed here because it leads to the iatrogenic injury to the infraspinatus muscle, and it helps to address the posterior slab and rotator cuff lesion. Low posterolateral portal, it is located 2 to 4 centimeter lateral and 4 to 5 centimeter inferior from the posterolateral edge of the acromion. It is located here, and it helps to remove the loose body from the axillary pouch, posterior capsular release, and inferior labral repair. Then the high posteromedial portal, it is located here 2 to 3 centimeter inferior to the spine of the scapula and 2 to 3 centimeter medial to the posterior portal, and it helps to you pass the thread in the retrograde manner through the infraspinatus tendon. And lastly, there is a subclavian portal. It is located directly below the subclavicle, 1 to 2 centimeter below lateral from the medial from the acromioclavicular joint, and it helps for the during the rotator cuff surgery. Thank you.
Thank you, Dr. Gurudev. Nicely presented on portal placement. Any questions from the audience?
For the beginner, those who have started doing this
Yes,
shoulder
the posterior portal is the foundation stone for your further any surgery of the shoulder arthroscopy. We generally do in the lateral decubitus position. The patient lies in the 30 degree of the posteriorly because you have to create keep the glenoid parallel to the floor. Then with your thumb 2 centimeter medial or 1 centimeter 2 centimeter inferior and 1 centimeter medial from the posterolateral edge of the acromion, press your thumb, there is depression or the soft spot between the infraspinatus or the teres minor or sometimes in the infraspinatus, and feel there is soft spot, then make a small skin incision and introduce your trocar and the sheath pointing towards the coracoid process, and ask your assistants to abduct, distract and pull the shoulder up so that you are getting the space between the moving humeral head and the fixed glenoid, and then you introduce your sheath. Once you puncture the posterior capsule, there is sudden loss of resistance. Once you feel there is some kind of resistance, don't force it, otherwise it leads to the cartilage injury. So you little bit angulate your trocar and sheath so that you are getting the space between the joint. And once you enter, don't allow to water saline to flow inside the joint. Push some amount of 20 cc air inside and then see whether you are in the joint or not.
It's the distraction of the shoulder joint. Direction is your, you should feel with one finger coracoid, another finger at the soft spot. And third thing, once your scope is in, directly don't open the water. You can see to it, you can put your, it's going smoothly or not. If it is going smoothly, then you can inject 10 to 20 ml of normal saline and see whether it's coming back or not. If it's coming easily, it means you are inside the joint. So these are the basic tips, particularly for the beginner. So you can start with the viewing portal. So once viewing portal you're perfect, so your 50% job done for shoulder endoscopy. Thank you.
And Dr. Gurudev, one more question. What are the neurovascular structures we should take care while putting the portal or making the portals?
So basically we are doing two surgery. One is the instability and another is the rotator cuff surgery. So anteriorly it is the musculocutaneous nerve that is more prone to the injury. So we are, before creating the portal, pass one line through the coracoid process. Never ever go medially to the coracoid. Always stay lateral to the coracoid, and the musculocutaneous nerve is 2 centimeter lateral medial to the coracoid. So there is very less chance to this nerve to get injured.
Thank you, Dr. Gurudev.
Thank you,
very much. Now I'd like to request Dr. Deepak Joshi. He'll be talking about anterior shoulder in
chairpersons, and very nice discussion on the portal. Very important, the portal placement. If the portal is wrong, everything is wrong. So I'll be talking on the shoulder instability now. So it has been discussed and we all know shoulder joint is inherently unstable joint. So it's like a big golf ball sitting on a tee. So the head is very large and the concavity is very small. So always inherently stable, and with these days with so much of sports, the unstable shoulder is always compromised to gain more mobility in so many professions, and we are getting injuries. So it can be completely dislocated, it can be recurrent subluxation, and since it is an inherently unstable, the anterior dislocation is more common than the posterior. Stabilizers of the shoulders always discussed. Management now, though this is very important now in 2015, 14, 15, all the shoulder dislocations, single dislocation we used to operate everything. So every time the Bengal repair used to be done, then we thought it's overdoing. So we now are conservative, so we wait for 6 weeks, and after 6 weeks we do all the tests that were discussed in the morning. So we have to do the test and see whether there is an apprehension. Then only the single dislocators are operated. Typically shoulder instability is a Bankard lesion, which is a 3 to 6 o'clock injury to the labrum ligamentous complex. So this is how it is injured. So these are various types of Bankard anteriorly. We can have just a soft tissue, we can have a bony Bankard, we can have a reverse Bankard, we can have a Perthes lesion which looks normal on arthroscopy. It's only when we probe then we can see. The typical lesion most commonly that most of us see is the Alpsa lesion, where is the labrum and the periostal sleeve is avulsed and it goes down to the level below of the glenoid. And we can have a glad lesion, which is basically there is an articular defect along with the lesion. So the most important thing that we should know that it's just interior dislocation is not just about the Bankard lesion interiorly, it is also about the Hill-Sachs lesion, which makes it a bipolar sort of a lesion. Anteriorly it's a Bankard and posteriorly it's an Hill-Sachs impaction fracture. So this is how the Bankard lesion looks like. That's on the left side is the normal labrum, on the Bankard lesion the torn labrum anteriorly. So when we think about managing this thing, so we have to go back to the Itoi and its concepts. Very good paper in 2012 was written by Balkart and Itoi. It's freely available on the internet. We have to know what is glenoid tract. Glenoid tract is the contact zone between the glenoid and the humeral head during the movements of the humeral head on the glenoid. So it's seen that they have found that during experiments it's 84% of the glenoid with the head is in contact with the glenoid, which is important for the bony stability of the shoulder joint. So let us see how it looks like. So this is how we measure. I will just tell you how it looks like. So if the Bankard track, the track is not normal and we are in a full abduction and external rotation, and the humeral head, the Hill-Sachs is going anterior to the labrum on the right hand side of picture, you can see then the lesion is off track, or there is a bony instability in here, and we may have to add something to the humerus also. And if it is not doing in full ABR, it is not going in front, the track is normal, then we can do just a simple soft tissue Bankard anteriorly. So how you do it? Measure the diameter of the glenoid in a 3D CT scan or an arthroscopy. Then determine the width of the anterior glenoid loss. How much percentage of the bone loss is there anteriorly? And with a formula, we calculate the glenoid tract, that is 0.83 diameter of a normal glenoid by the circle method, and we subtract how much millimeter the glenoid loss is there. So a short video how it is assessed. So that's by the circle method. You can see this is how in the center by the circle method there is this much of the glenoid loss is there, and then there is a bare spot. If you look, we are looking from the superior portal, we are putting a measuring device from the posterior portal, and from the bare spot, that is the thinnest spot on the glenoid, which is the center point of the glenoid, we measure how much percentage of the bone loss is there. Then we calculate the Hill-Sachs lesion, which is actually the width of the Hill-Sachs, how much the bone loss is there on the or the humerus, and the bony bridge in between the rotator cuff and the attachments of Hill-Sachs. That is the Hill-Sachs lesion. You can see in the video how it looks like. So this is how we measure the Hill-Sachs, actual Hill-Sachs bony defect on CT scan. And then we also calculate the bony bridge from where actually the rotator cuff is inserted. So that is actually in contact with the glenoid in full ABR. So this is, you can see the big Hill-Sachs, and we are looking from posteriorly, and we pass a measuring device. So which is, whatever is raw is the Hill-Sachs, and whatever is not raw, it is the bony bridge. It is where the pits are there and which is normally present. So we should know what is Hill-Sachs and what is a normal humerus. And this is how we measure the Hill-Sachs lesion. And then apply the formula. If the Hill-Sachs lesion is more than glenoid tract, then it is off track, and if it is less than GT, then it is on track. And then we put a formula, and we then decide what we should do. If it is an on track lesion, we just do a Bankard repair. The glenoid defect, this is the earlier Itoi Balkart paper. Now it is 20%, we take it 20%. If 20% bone loss is there, then we can go for a normal Bankard, but if it is more than 20%, we go for a Latarjet procedure. If it is off-track lesion, less than 20% loss, then we add a remplissage to the humerus. And if it is more than 20% loss, then we do a Latarjet. If it is more than 25% off-track, then we do a Latarjet or remplissage or a humeral bone grafting. So I think how much time I have, but I'll just try to skip. So this is how it looks like on a, if you look at the video, this is how it looks like, the Bankart lesion anteriorly. You can see the, and here is the remplissage, the bone defect, which is posteriorly. Just give me just 2 minutes time. So this is how we go from a looking from a superior portal, and we put an anchor on the Hill-Sachs. We made the humerus raw. We place an anchor. So we can use Marius anchor. I am using these days all sutures anchor here also, but we can use a metal or peak anchor here. We can do a 4-loaded. I generally use a single loaded anchor, and we take a bite through the capsule. So remplissage is basically to fill the defect. And this is how we take another bite from the posterior capsule. So this is being done for a off-track Hill-Sachs lesion. So we take a bite, and so this is, you can see a capsule and a part of infraspinatus go. So we put a anchor on the humerus that is between the cartilage where the bone loss is there. It's somewhere between. We are not too much anterior so that we don't restrict so much of movement. We are somewhere in the middle, and this is how we take a bite, second bite. So if I just make it little forward, so these are the bites are taken now posteriorly. When I pull these threads, you can see how the humerus head sits down, and then we do a Bankart lesion. I am seeing from the posterior portal, and putting an inferior most anchor. The most important thing that we have to know is whether we are using all sutures. This is a biocomposite anchor that we are using. So we place an anchor onto the glenoid face, and we are around 5.5, and most important thing is that we go below the anchor and we retension the ligament. Unless and until the ligaments are retensioned, you can see the ligaments are pulled upwards, then only the patient will have good proprioception. So you can see the bite is taken from inferiorly, and the capsule is shifted from inferior to superior. And this is how the next anchor, this is how the knots are put, and the Bankart is tied. So the second anchor is put, Bankart is tied onto the face. Third anchor is put at the level of subscap, which is 3 o'clock position, and this is how the bite is taken and it is pulled. So once we do this, after that you can see that's a subscap here. So at the level of subscap, this is subscap, 3 o'clock position. So the 3 anchors, the Bankart is fixed, and then we fix the remplissage. So now we are tying the remplissage. We are going posteriorly. You can see how it looks. We go posteriorly. This is how we tie it. Rehab is slow, sling for 4 weeks, and external rotation after 4 weeks only. And the ABR is, abduction external rotation is allowed after 6 weeks in these cases. I think the time is over. I'll skip the Letarge procedure. It's only that we all know that we have to transfer the coracoid to the anterior glenoid. So this is how it's done. You can see the coracoid is taken, and we just osteotomize the coracoid. We measure it. We go between the subscap. The most important thing is that it has to be flush with the glenoid. So that's the glenoid, and there's a plate and the 2 screws being put. So you can see there's a glenoid inside, you can see, and the subscap is split, and we just put it at the face of the glenoid, and it is neither overhanging nor basically going behind. So take home message is bone stability is very essential component for shoulder instability, and conversion of an off-track Hill-Sachs to an on-track Hill-Sachs is essential for stabilizing the shoulder. Thank you so much.
Thank you, Dr. Deepak. And any question from the audience?
Dr. Deepak, thank you for a very nice presentation and clarifying the concepts of on-track, off-track lesion. Just a small question. Do you differ in your plan if you have a patient who is an active overthrowing athlete? Because you're in a sports injury center, do you make any changes to your plan?
Tendency of doing a Letarge is more in a sportsman people. So we just see how much bone loss is there. But still, I think I will, if it is borderline, say 18-19%, I'll go for a Letarge.
Sure.
But if it is 15%, I'll still do a same the Bankard. I think we are doing in lots of wrestlers and lots of things. They, I think, do reasonably well with a normal Bankard procedure. It's
My
only that tendency to a Letarge increases more in these.
The experience has been that if you do remplissage in these overthrowing athletes, you restrict the external rotation even more.
I know that is a thing, but it is very less. Well, I have not seen in my practice too much of restriction in movements.
Okay.
And the wrestlers, you have to look at the profession where you are doing. If you are doing in a gymnast, then I will not tend to do a remplissage. If a wrestler, will do a wrestler because he doesn't need that much of external rotation. So in a pole vault thrower, I will not, tendency is again not to do a remplissage. It depends on what is the profile of patient, how much external. In a boxer, I will not do a remplissage.
That's great, thank you.
Very basic question, sir, particularly for all these beginners. The first time dislocators, he dislocated his shoulder and reduced somewhere else and reaches to you after 1 week. That is very common scenario to all of us. 22-year male, first time dislocator, get reduced and reaches to you after 1 week. What is your approach?
I will just immobilize the patient for another, I think, 3 to 4 weeks and then start mobilizing the patient. At around 3 to 4 weeks, I will get an MRI done. If it's a bony
lesion and mild Hill's axis there.
If it's a bony Bankard, that is an
bony Bankard, sir. It's the Bankard, soft tissue Bankard and mild Hill's axis there.
If it's a bony Bankard, then surgery. If not a bony Bankard, then examine him after 6 to 8 weeks. Most of the times, I think I will write 9 out of 10 times the patient doesn't have any problem.
Yeah, so
no
this
apprehension.
Is the point.
So no
this
apprehension,
is the point.
no surgery.
Yeah. So this is the point. It should not like the first time dislocator don't need surgery. It's the examination at the end of 4 to 6 weeks. If that patient is having apprehension, he must need surgery. If no apprehension, no bony glenoid lesion, no surgery. So this is the message. Thank you, sir.
Thank you, Arvind.
Hello.
Deepak, and Dr. Arvind has also helped in clarifying few facts. Surgery should not be embarked immediately after injury. That is the message. And I would like to request Dr. Abhishek Das. He will be talking about instruments and equipments used in shoulder arthroscopic procedure.
Good morning, everybody. I hope all of you are having a nice time with this academic fest, and thank you PMCH Patna and the organizing committee for giving me the opportunity to present a talk. This is a very vast topic on instrument and equipment, and I'll try to cover as much as I can so that everybody can safely do the arthroscopic surgery for the shoulder. So when we talk about arthroscopy, the things start from patient positioning. So there are two prime positions in which we do our shoulder arthroscopy. One is lateral decubitus, which is probably more common in this part of the globe as compared to UK, where I had the opportunity to get trained, where prime focus has now been the B chair position. So for lateral decubitus, what do you need? You can do it on any table where you do a total hip arthroplasty, provided you have some clamps to put the patient in a lateral position, but you need a traction device to hold the arm in about 30-40 degrees of abduction and in a bit of traction. Now, how much weight do we need to put in? About 2 to 3 kgs of weight is enough, and you need an assistant who can give an abduction when you are doing the, when you are inserting your trocar and sheath. Now, the challenge is when you try to do this in a B chair position, you need a lot of other equipments. Probably on the right hand side, you can see a specialist shoulder table, where the difference from the normal table is that when you place the patient in a B chair position, you can remove all the attachments on the side of the shoulder, because you'll need an access to the medial side of the shoulder to place your scope and sheath. Otherwise, uh, the shoulder pads will come in your way when you are trying to put your light source, when you try to visualize laterally. Most of the visualization in the shoulder is kind of by rotating the light source. And when you try to rotate the light source medially so as to visualize things on the lateral side, the table will get in your way. Now, shoulder table, buying a new shoulder table is a costly affair. So what can you do? So then coming to the middle, Smith & Nephew or other companies have got something which is called a T-Max. It is an attachment. So if you look here, on a normal table, you remove the head end part of the table and you can attach the whole shoulder piece to it, which has got something to hold the head, and one side of the shoulder attachments can come off. Now, what do you do if you are a surgeon like me who doesn't have either a shoulder table or you do not have a T-Max attachment, but you still want to do in a B chair position? So this is my setup. So what I do is on the normal table, I put the patient in reverse Trendelenburg position, then break it at the hip and the knee, lift it up, and once I've got the patient in my desired position, which is around 60 to 70 degrees, I pull the patient as far lateral as I can, almost to the point that the patient is hanging off the table. Then I place the head ring, secure the head with lots of bandages, because you have to make sure that you do not cause any cervical injury. Now your shoulder is almost hanging off. Then I put a clamp on the side of the hip so that the hip doesn't fall off, and the clamp has got a handle, and the arm rests very well on that clamp. Now, if you have got a luxury, then you can have this gadget, which is a glorified 10 lakh assistant. This is the Trimano, which is hydraulic arm positioner, which can hold the hand in any position you like. Again, I do not have this, but I have got two assistants who can do the job of Trimano very well. The only problem is they get tired, and if you ask them to hold in 30 degrees of abduction, after 5 minutes, it will be in neutral position. So these are the problems, but as a thinking surgeon, as a surgeon who wants to do things his way, you have to design and devise the methods to suit your needs. You do not change the surgery as per the table or as per the things given to you. You make changes so that it is according to you, because you are the surgeon. You need your convenience, because that will influence the results. Because if you have done the surgery in lateral position, say in lateral decubitors, you will find it very, very disorientating if you do it in a B chair position, and vice versa. Now, basics of arthroscopy, what do you need? You need a trocar and sheath. You need at least a 30-degree 4-millimeter scope. And if you have the luxury, you can get a 70-degree scope as well. You need a decent enough camera. Then, the other important thing without which I don't think arthroscopy is possible is a good shaver device. Now, in shaver, you have to be very careful when you are purchasing your equipment, because the cheaper versions will have a very heavy handpiece. And say if you are doing in lateral decubitus, you will find that your hands are like this. And slowly you will start getting tired if your handpiece is very heavy. So invest a little bit in it so that your handpiece is a bit light, and it has got both the options of operating it with a foot switch or operating it with the switch on the handpiece itself. Because sometimes you have too many things on the hand, then you want your foot to work for you and you can press the pedal. You cannot rely on somebody else to press the pedal for you. And then the other important bit is lots of this burrs and shaver. Now the problem I had last week was I had posted a case for rotator cuff repair, and then when I asked, well, everything is ready, but then we didn't have the burr. Burr wasn't available in Patna. So this is another challenge. So you need to think of everything. Now without burr, how are you going to do your subacromial decompression? So sometimes things that can help you is, my better half is an ENT surgeon, so I borrowed her microdebrider and then did the subacromial decompression with the shaver and the microdebrider, but that was a learning lesson for me. So I purchased a burr for myself so that I can use it. So every step you have to think. Sometimes, one shaver is good enough, but you will feel that you are stuck. You may need, rather than 4 millimeter, you might need a 5 millimeter shaver. A burr, sometimes 4 millimeter is not good enough. It is not doing the job. The bone is very hard. You might need a 5.5 burr. So slowly and steadily, you'll get used to it, but try and have at least one shaver and a burr with you all the time. Now, this is the stack. This is the placement of the stack. And if you go back to the actual positioning, you'll find that everything is arranged in order, monitor, stack, and that is on the opposite side of the table where you can visualize it without having to tilt and turn too much. So try having this kind of a stack where everything is in order, and train one of the assistant who is good enough to handle all these equipments. When you say, well, I need the pump pressure at this much, he can quickly press a button without you having to focus. Okay. Fine. I'll try to speed up a little bit. Okay, fine. The other most important thing is the fluid management system in the shoulder. In knee, it is not that much important, but in shoulders, you need a fluid management system to keep a pressure decent enough, because turbulence will again cause bleeding and your vision will go away. So a fluid management system where pressure can be controlled is very important, but then again, you will have to invest in the tubings and things which are not probably reusable. RF coablator, Dr. Rakesh sir has dealt with this in a lot of detail, so I won't go into it, but this is again another device which is very, very helpful. Now, you need a few of these. Previously, they were reusable. Now you have got disposable ones which you can reuse, and there are variety of cannulas. One is a screw-in cannula, which is the go-to device, but then again on the top, you can see the passport cannula, which actually gets stuck in the deltoid sheath and is very, very good if you are doing rotator cuff surgery. These are variety of instruments, but I won't go into detail of all of these, but a few which you need is a suture passer, and this is a good one which has got a bit of a hook on it, and it can retrieve your suture as well as tape, because when you are doing rotator cuff surgery, you need a tape retriever as well. Then you need a suture retriever, a grasper, knot pusher, knot cutter, and then something like a duckbill punch. Now, all of these equipments have got straight, right, left, up biter, down biter as per your convenience, but once of each of these handheld, there are lots of suture, and shoulder surgery is equivalent to suture management. So whether you're doing Bankart surgery or rotator cuff surgery, you can start off with something like this, which is a clever hook or a rhino from the other company, and they have got nice tip which with you can pierce the tissue and then retrieve your suture. Now, they also come in straight, right and left, but something which can make your life slightly more easier is this suture lasso, which has got nicely curved tip, which you can rotate and pass it, and then it has got a nitinol wire which goes inside, and through which you can pass your suture and retrieve it. Now, if you want something more fancy, then this is your go-to thing for at least the rotator cuff. This will make your life very, very convenient. It won't make it very easy, but it will make it very convenient. These are the grasper sutures. First Pass Mini, which is the cheaper version of Scorpion. Scorpion comes with a needle, which after 4 or 5 uses, you might have to change it. But with this, you can get a very good bite of the rotator cuff, fire it, and like the Scorpion tongue, it comes out and pierces the rotator cuff. And you can, at the same pass, you can retrieve the suture. And if you can invest in a little more, then you can get a multi-fired Scorpion, where you can pull all the sutures at one go in the needle and multi-fire and retrieve them with a single pass. So these are advancements to make your life easier, but at least you can have something basic like a First Pass Mini to make your rotator cuff surgery easier. Coming to suture anchors, there are varieties of these in the market. You will have to decide what you want to do.
Patient is ready for surgery. So
oh, okay, sure.
Conclude.
Sure, thank you. We'll cover this in some other talk.
there is no question answer, so we fast, and I would like to invite our all speaker, Dr. Rakesh Chaudhary, Dr. Gurudev, Dr. and just come on the stage. And I would like to invite uh, to felicitate our first speaker, Dr. Rakesh Chaudhary. Thank you, sir. And our next speaker, Dr. Gurudev. And I would like to invite our Dr. S.S. Jha, sir. Please come on the stage and felicitate our speaker, Dr. Gurudev. Thank you, sir. And stay there, sir. I would like to invite Dr. Ajay Kumar Manav, sir. Please come on the stage and felicitate our Dr. Deepak Joshi. Dr. Deepak Joshi, please come on the stage. Thank you, sir. And our speaker, Dr. Abhishek Das. And I would like to invite Dr. N.K. Singh, sir. Please come on the stage and felicitate our speaker, Abhishek Das.
Before we go on for the live surgery, may I request our President, Dr. Ranjit Singh, to kindly facilitate our two chairpersons. Please, sir.
Hello.
Dr. Ritesh.
Hello.
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 Sir, mic
Just a minute. Let it the award function be over.
Yeah. Okay, thanks
Yeah.
everybody.
Yes,
Now
Devendra.
I hand over to
Dr.
Dr.
Rakesh
Sandeep.
Chaudhary, are you listening me?
Yes, very voice is very clear.
Right.
I will
Can you
handing over to the
see the
moderator of
surgeon,
this
Dr.
session,
IPS over
Dr. Abhishek and Dr. Sandeep, to kindly come to the dais and moderate. I will request all the delegates to keep on asking question whatever they want, be it any crap question. Still it will be
Drill bit
counting.
देना उसकी fast,
Just keep
उसकी
on
push
asking
lock की.
question. It will help you a lot. Just saying, and if you are not understanding, you
Hammer
just seeing
चाहिए.
it won't be helping you
पुश
much.
लॉक के लिए
Okay.
ट्रोकार होगा इसके लिए
I have tried, asked them to do, teach you everything, right from the
और,
draping to everything. So first session will go on like that.